So turning to the question of of possibly new strategies, as Dr. Chura mentioned, it's a really, I'll use the term remarkable time as somebody who has been involved in this area for over 30 years in terms of new opportunities for therapy. And one of the, obviously, most exciting is this class of drugs known as PARP inhibitors. So we'd like to talk a little bit about the PARP inhibitors. So Justin, what are the PARP inhibitors and how do we believe they work in ovarian cancer?
Okay, so we'll talk first about Anya actually has a BRCA mutation. So she has inherited one of the genes that predisposes her for high risk of both breast and ovarian cancer. She's had the disease of ovarian cancer. We know that the BRCA genes are involved in when cells replicate and they duplicate their DNA and have to match it up perfectly. That fidelity, if there's a loss in that, that's where the BRCA genes work. They ensure that there's correct replication. And so cancer cells, to grow, need to replicate and divide. And when they already have a defective gene in the BRCA pathway, so they're a little bit predisposed to not being able to correct the errors in replication, and we add in a drug, a PARP inhibitor, which also acts along that same pathway of what's called homologous recombination. So that's a bit of a mouthful. But we add in a drug that also acts along that homologous recombination pathway. In a patient with a BRCA mutation, or even now without, we know that that interferes with the cell's ability to replicate and grow and divide. And so that's sort of how we think the PARP inhibitors work. And the first glimmers of hope were most in patients with the BRCA mutations because they have already a predisposition that their cell lines are not going to be able to replicate in a reliable fashion. And so we add in this medication that further works along that way. But that's talking about what we call a genotype, someone's inherited genes. We've also identified what we call a phenotype. Phenotype, on a surface, what does somebody look like? Our phenotype is whether we're blonde-haired or brown-haired, but we've identified a phenotype called HRD, homologous recombination deficiency. And so that phenotype, which can be identified through testing of the tumor, can be identify another subset of patients that can particularly benefit from PARP inhibitors.
One of the questions has come up, and you mentioned about BRCA and the germline, which obviously means that it is present in every cell from conception onward. The possibility that those mutations can be just in the cancer cell itself, and the term we use is somatic. Does it make a difference, or from the perspective of the potential benefits of these PARP inhibitors, if it's only in the cancer versus the germline?
Well, certainly it makes a difference for the individual patient and her family when it's not in the germline. So that's a key thing to remember. And when patients have a germline BRCA mutation, we have to think about children, siblings, and really extend that out in terms of who is at risk. When it's a somatic mutation and just in the cancer itself, those cells are then still exquisitely susceptible to PARP inhibition. And so I think that having the presence of the mutation when it is just somatic still is a very good marker of what will the cancer respond to in terms of therapeutic options for the patient.
So one of the issues then comes up in discussion about potentially using PARPs, as you alluded to, is even if an individual does not have a known BRCA mutation. And in fact, BRCA mutations are now recommended to be looked at long before we are talking about potential therapies with PARPs. It's now recommended early in the course of the illness, really at the time of diagnosis, by a variety of groups, because the question then comes up of if there's that family risk of identifying that information for both women and men in that family, children, grandchildren, nieces, nephews, etc. So that information may be available, but even in the presence of a normal BRCA mutation, there could be the absence of a BRCA mutation in terms of the germline that could be in the somatic area. So that's a reason to look. But another question that comes up, and including in the available data, that patients with ovarian cancer seem to benefit from these PARP inhibitors, even in the absence of a BRCA mutation. Want to comment on that?
Absolutely. So it's definitely a complex question, and it leads into how we use the PARP inhibitors. So the first approval in 2013 was for a PARP inhibitor in patients with a BRCA mutation who had more than 3 lines of therapy. And that was approved as a treatment, and those patients had to have the germline BRCA mutation. There's been other approvals for either germline or a somatic mutation for treatment in patients with 2 lines of prior therapy. But we've also studied PARP inhibitors in what we call maintenance or switch maintenance, where patients have to be what we consider platinum sensitive, meaning that they respond to platinum-based therapy, and we treat with a platinum-based regimen, whether that's carboplatin and any of the other chemotherapies we might combine it with. Assuming they achieve either a complete response or a partial response, those patients are then eligible for PARP inhibitors regardless of their BRCA status. We know from some subgroup analyses that the patients with the BRCA mutations will have the most profound benefit, but even those without still experience a clinical benefit in what we call their progression-free survival, so that the PARP inhibitor can extend, if you will, the remission to a degree. And so in that setting of what we call maintenance or switch maintenance, that's where PARP inhibitors can play a role regardless of the BRCA status.